Chapter 7 is coding guidelines for procedures and operations. And due to the size, we are going to need to break this down into two distinct parts. So our friend the UHDDS, the Uniform Hospital Discharge Data Set, requires all significant procedures to be reported. Medicare also requires the reporting of any procedure that affects payment, whether or not it meets that definition of a significant procedure. Other procedures may be reported at the hospital's discretion, and that's one of those things that we will find differences among our various facilities in our area. Electronic claims allow the coding of up to 25 procedure codes. At the present time, Medicare allows the reporting of 6 procedures. If more than 6 have been performed, all therapeutic procedures, particularly those related to the principal diagnosis, should be reported to the most extensive possible point. Effective January 1st, 2011, Medicare expanded the number of ICD9 diagnoses and procedures it will accept and process on their institutional claims. The HIPAA code for Volume 3 is the standard for hospitals when reporting surgery and procedures for inpatients. The American Medical Association's current procedure terminology, CPT, and the Healthcare Procedure Coding System, HCPCS, Level 2 codes, rather than Volume 3, are the standard for reporting hospital outpatient procedures and physician reporting. The principal procedure is the procedure most related to the principal diagnosis. If 2 procedures are equally related to the principal diagnosis, the most resource-intensive or the complex procedure is usually designated as principal. It is important to follow the UHDDS definitions since principal procedures are significant in the reporting of surgical quality indicators. Certain procedures are performed only for specific conditions. Care should be taken that the associated diagnosis code is also assigned. Your principal diagnosis should correspond with the principal procedure in most cases. However, every now and then it may not correspond, which would cause an edit with the grouper, and usually that edit refers to procedure unlikely to occur with principal diagnosis. If the edit appears, that does not necessarily mean that the coding is incorrect, but you should review the record to determine the principal procedure and that the principal diagnosis are correct. For an example, repair of a retinal detachment generally occurs as a result of a retinal detachment. So that would be a corresponding or a comparable principal procedure and principal diagnosis. But what if we have an individual who was admitted for pneumonia of the right lung, but the principal procedure, the most surgical, most complex procedure, was an open reduction of an internal fixation for a fracture? That's going to come up as an unlikely edit, and that may be appropriate because it's very possible we could have a patient admitted with pneumonia, somehow falls while they're hospitalized, and we have to repair it surgically. Volume 3 for the procedures is organized by body system. Most of the chapters deal with a very specific body system, but we do have a couple exceptions. Chapters 0, 0, and 17 capture procedures that correlate to all body systems, and they're in place to help accommodate new technology for additional code expansion because there was no additional room within that specific body system. Chapter 13 addresses obstetrical procedures, and Chapter 16 identifies and classifies diagnostic and therapeutic procedures that are not considered surgical in nature. As we talked about earlier in Module 1, the procedure format for ICD9 codes are either 2, 3, or 4 digits, and we need to be really in tune to that. 2 digits proceed to the left of the decimal point, and then you will need at least 1 or 2 digits following the decimal. ICD9 CM Volume 3 also has coding conventions, and you'll see the terms code also instructional notes and then the slanted brackets. That code also instructional note is used to indicate that an additional code should be assigned if the reference procedure was performed. It also is used to apply to two very specific conditions: to advise you that an individual component of a procedure or that two procedures together are considered a unit and both may be coded. So you'll see the phrase code also any synchronous, and then it would identify the condition or the procedure. We also have slanted brackets that are used in the index, and these are used to instruct you or provide you instructions to assign codes for two closely related procedures by enclosing the second code in the entry in a slanted bracket. It indicates that both codes must be assigned and sequenced as indicated. Main terms in the Volume 3 index are generally used as identified under the general type of procedure: an incision, an excision, implant, insertion. A few are also indexed by the common name of the procedure, such as a hysterectomy or an appendectomy. So you're not going to go to excision or removal of the uterus. You can go right to hysterectomy. Subterms also are introduced with the words with or without that immediately follow the main term. There are a couple exceptions that you'll see, and other connecting words are by, for, and to. So there are cross-references within the Volume 3 index. They're used just like what we see in the diagnostic index, and you must follow those cross-references to be able to find the appropriate code and to accurately code. It is often necessary to refer to a synonym or a general term to locate that appropriate code assignment. Volume 3 uses a lot of eponyms. Surgical procedures are sometimes identified by the eponym, and it's usually in reference or to give credit to the surgeon who developed the procedure. When there is no entry for the eponym, consider what that procedure really is and refer to the main term that describes the procedure. You may find the terms or the codes indexed under the eponym. You may need to refer to the main term operation and then look for the eponym as a subterm, or as a main term or subterm under the procedure that describes the operation. So excision or removal of an organ or a lesion. Removal of an organ is usually listed by site under the main terms excision or resection. You are going to have to look under both. If you start under excision and you don't find it, you have to go to resection. So we often remind coders to put a little note next to excision and resection to refer them to the cross terms if your particular publisher hasn't done that. When only a lesion of the organ is removed, you're going to want to check under the term excision and then look under the subterm lesion with an additional subterm identifying the specific site. Now, ICD9 procedure codes do allow us to assign a code more than once, and that is allowed for bilateral procedures. An example would be a major procedure such as a joint replacement, and you would code that code twice. Some codes do make a distinction as to whether or not the procedure is performed unilaterally or bilaterally, so you're going to want to search your subterms to make sure that you don't miss that. Codes for less significant procedures may also be assigned twice when it meets the criteria of a significant procedure. In most cases, it's not useful to do so, and an example of that would be an excision of a skin lesion. You wouldn't need to code multiple times if you have multiple skin lesions. Just picking up one excision is significant. So let's talk about the coding of operative approaches and closures. No code is assigned when a definitive procedure is carried out, except in the rare situation when the code for the surgery does not imply the approach. Both the alphabetical index and the tabular list often instruct the coder to omit the code when it represents the operative approach. But this is not consistent within the index and within the tabular list for you to rely on it. So you can't say, oh, there's no omit code direction, so I have to apply the code. It really requires you to take a look at the description and say, does this really tell me how that procedure was performed and what the approach was? Laparoscopic, thoracoscopic, and arthroscopic approaches are now being used for a number of procedures that have only previously been carried out by an open approach. These procedures are less invasive and usually result in less trauma to the patient, allow for an earlier discharge from the hospital, and a more rapid recovery. Other endoscopic approaches are coded unless the alphabetical index directs you otherwise, or the code title indicates that the procedure was performed by endoscopy. When an endoscope is passed through more than one body cavity, the code for the endoscope identifies the furthest distant site that it entered. It is possible that a procedure, a laparoscopic or an endoscopic procedure, is converted to an open approach. That may become necessary to complete the procedure. Only when that occurs, only the open procedure is coded. There is no way to appropriately capture the laparoscopic or the thoracoscopic approach. And we give you some examples. V64.41 from a diagnostic standpoint allows us to show that there was a laparoscopic surgery that was converted to an open. So it's not that we don't capture it, we just don't capture it at the procedure level. We're going to capture it at the diagnostic. So we're going to stop here. Part 2 will pick up some very specific types of procedures.